Hello, everyone, and welcome to this month's Learning Collaborative meeting on anti-epileptic medications. We will have a discussion on the didactic followed by a quality improvement discussion.
Hi, good day. As we were told, we're going to give you a little bit about anti-epileptic medication. This is a very thorough and long discussion, and there's a lot of information. So what we're going to try today is just to kind of touch a bit on some of the more common medication and just give you a little bit of an overview. How do we choose medication and what is their mechanism of action? So one of the important things to know is treatment with anti-epileptic medication does not actually alter or impact the prognosis of epilepsy. Therefore, it does not really matter regarding long-term whether we start treating immediately or whether we wait. Of course, it impacts our relapse rate by about 50%. So we're improving mortality, we're improving morbidity, we're improving quality of life when we start treatment. However, if we are dealing with an epilepsy syndrome that is supposed to relapse at one point and go into remission, the child will go into remission with treatment or without treatment. The thinking on when to start anti-epileptic drugs is actually the recurrence risk after one seizure. There's about 30 to 40% of children or adults may have one seizure and never have seizures again. And therefore, in many instances, we will not start after one seizure. Usually, after a second seizure, the recurrence rate goes up to 80%. And the traditional way of treatment was to wait until the second seizure before we start the treatment. However, lately there was some changes in the definition of epilepsy, and now we know that if a child or an adult had one seizure, but then has some risk factors that increase the recurrence to over 60%, we should consider early treatment after the first seizure. So for instance, if you have an abnormal EEG with frequent epileptiform discharges, or if the child has a lesion on an MRI, the chances for second seizure are much higher. We most likely will already start the treatment after the first seizure. We have to consider that any anti-epileptic medication is actually a poison in high doses. So if we have to treat, and we treat, we have to think about the side effect profile, and to try and use the lowest dose. So the decision to treat is actually a risk-benefit assessment. What is the risk, morbidity, and mortality of the seizure? And what is the risk of the medication? And what is the ratio between the risk and the benefit? So it's very individualized. If we have an adult who is a truck driver and had one seizure, most likely we are going to start treatment after the first seizure. If we're going to have a child who has a benign epileptic syndrome and the seizures are very infrequent, we might not treat at all. It depends on other medical problems. Sometimes there are comorbidities that would push us to treat with a specific medication. And sometimes it's the patient's or family preference. We have families with young children who have infrequent seizures, mostly nocturnal, and they do not want to start treatment. On the other hand, we have patients or families after one seizure, and it was so frightening and causes so much distress that they would like to start treatment after already one seizure. So how do we choose the right anti-epileptic drug? Of course, we would like to choose a medication that is good for the seizure type. So we have some medication that are only covering focal onset seizures, while we have medication that are more broad spectrum. And then medication that are good for a specific epilepsy syndrome. For instance, childhood absence epilepsy, they have absences. We're going to try and choose a medication that is good for abscesses. The mechanism of action of the medication, and this is very important because nowadays, for instance, we have some genetic epilepsies like Dravet syndrome, where we know that we should not choose a medication that works on the sodium channel because this might actually worsen the seizures. What is the ease of introduction and what follow-up do we need to do? So a child who cannot swallow pills, we can not use medications that have only a pill formulation and no elixir. We can usually not use maybe a long-acting medication. A child who suffers from autism and has a very hard time with blood draws, we cannot choose a medication that needs frequent monitoring with a blood drawing. Then we have to think about the interaction with other drugs if the child is on other medication. What is the safety profile and adverse effects? And sometimes we use the adverse effect as a benefit for some comorbidities. For instance, a child who is very obese, we would like to maybe choose a medication that decreases appetite compared to a medication that increases appetite. And then, of course, in our world, we deal with cost and insurance and what medication we are allowed to use as the first trial. Not all of them are we allowed to. And of course, there's prioritization. So this is a big deal nowadays. Our goal for treatment is no seizures and no side effects. So that's the optimal that we would like to get. Of course, not always are we able to get to that goal. And the second goal is to maximize the quality of life of the patient. So even if we cannot control all seizures, we would like to improve the quality of life.
Renat, can you go back a slide?
Yep.
I think the only thing I would add there, and it's really included in what you have, which is ease of introduction, is that some of them can be started quickly. And so if you have somebody who's very sick and having lots of seizures, we might pick something like levetiracetam or oxcarbazepine. Whereas if we have a lot of time and there's infrequent seizures and low risk, we might pick something like lamotrigine, but it could take 8 to 12 weeks to really get that on board.
Yeah, that is a very important point. We are quite lucky today. If you see the development of the anti-epileptic drugs over the years. We have so many more options compared to what we had even just in the 1980s. So the medication that you see here in yellow are our classic traditional old generation medication, or what we call first generation. And this includes all the medication that we know and see probably on a daily basis, like phenobarbital, like phenytoin, like etoxoxamide or zerontin, like sodium valproate, like carbamazepine or trileptal, and different benzodiazepines. The second generation are the medication that came out between 2000 and 2010, 2012, 13. And they include, again, medication that we use quite a lot, like the levetiracetam or Keppra, like the topiramate or Topamax, like felbamate, lamotrigine or lamictal. Then the fosphenytoin, which is an IV formulation of phenytoin, and we can administer it much faster and it has less side effect. The oxcarbazepine, trileptal, the zonisamide or zonogram, and then some of the more medications like vigabatrin that we use for spasm. And interesting, clobazam, who is a medication that was out in the market already in the 1970s, but was used mostly for anxiety, was just a few years ago FDA approved for epilepsy, especially with the Lennox-Gastaut syndrome. Then we have what we call the third generation, which is a medication that came out in the last few years and include rofinamide or benzel, lacosamide or Victat, Parampanel or Fycompa, and then the brivaracetam, which is, let's say, even a better formulation of similar to Keppra or levetiracetam. Some general facts about the anti-epileptic drugs is that they have usually good oral absorption and bioavailability. So for instance, Keppra, to give it IV or PO, is almost a quite similar absorption, almost a very similar time of onset.
Excuse me, Renat. Let's just pause for 1 second and welcome this new caller because there's a lot of static on the line. It's overpowering your voice. Why don't we welcome? I think somebody's just joined us. Can you say hello?
Hi, it's Dr. Dolan.
Hello, how are you?
Good, thanks. I couldn't connect by my computer.
That's
I didn't
fine.
recognize the link, so sorry about that.
Oh, no worries. What I'm going to ask you to do until you really want to ask a question is maybe just mute for a few minutes because it's creating some background noise. It might be just
okay.
moving around.
Okay. All right.
If you're on your phone, you can just mute and then unmute when you want to ask us a question. And then Renat was just starting the presentation. I'll have her continue once you feel all situated there. And we'll send these around also by YouTube station in the future. So you'll get to watch it at some point.
Perfect.
Are you
Great.
able to
Thank
see
you.
or you only listen?
I think she's I'm not sure.
She's just able to listen right now.
I think so. I think we're good. I just didn't want you to get overpowered. I wanted to be able to focus on what you were saying. That's great. I think we're good to go.
All right, so we'll continue. So I'm going to continue with a few facts about the anti-epileptic drugs. And I just talked about the fact that most of them have good oral absorption, except for instance, phenytoin, that in young children is really not well absorbed and is very high to get good levels. Most are metabolized in the liver, but there are some exceptions. For instance, levetiracetam is usually excreted in the kidneys. And interestingly, we just saw how many new medication we have in this last 20 years, what we call the second and the third generation of the anti-epileptic drugs. The sad fact is that despite the fact that they have better side effect profile, we actually are not able to get better seizure control. So they are not more efficacious than the classic older generation medications. A little bit about the mechanism of action of the anti-epileptic drugs. So what the anti-epileptic drugs are trying to do, they're trying to reverse the pathophysiology of seizures. So we know that we have a seizure when there is some kind of an imbalance between the excitatory mechanisms and the inhibitory mechanisms. And the medication are exactly trying to do the opposite. So the medication are trying to decrease the excitation or increase the inhibition. And they're able to do that through few mechanisms. One would be to increase the GABA mediated inhibitory system, or to increase, or to decrease the glutamate, which has the MNDA and the AMPA receptors mediated excitatory system. So less excitation and more inhibition is less seizures. This can be also done through direct blockage of gated mediated positive current channels like the sodium channel or the potassium channel, or through a direct increase of the outflow of positive potassium channel. So that's kind of in general how the medication works. And most of our medication, or let's say at least the newer generation, or to some degree also some of the older generation, they have an effect on multiple mechanisms together, maybe usually one mechanism that is the most prominent, but then they have also some effect on other mechanisms. And I put here into a table some of the medication that are more common, used by us and known to us, how they work. So for instance, phenytoin, carbamazepine, lamotrigine, topiramate, and valproic acid have a direct effect on the sodium channel, while we see that valproic acid also enhances GABA transmission, so has kind of a dual effect. Ethosuxamide and valproic acid, again, working also on inhibition of the calcium channels. On the other hand, the barbiturates, the benzodiazepines, gabapentin, vigabatrin, and again topiramate and felbamate enhance the GABA transmission, so enhance inhibition. And then felbamate and topiramate inhibit excitatory transmission through glutamate. So we see a medication like topiramate that has three mechanisms of action: blocking the sodium channels, enhancing GABA receptors, and which are inhibitory, and inhibiting excitatory glutamate transmission. And I think this is kind of maybe a little bit too detailed, but we thought to leave it here just that you know, whoever is then going to be interested to have this slide to remember how the medication work. And it's a cartoon that shows us the excitatory synapses and the inhibitory synapses on the left, the excitatory on the right. And again, we see how the medication can either block directly the voltage-gated sodium channel, and by doing that, they are inhibiting the action potential, inhibiting the depolarization, and inhibiting the release of the excitatory glutamate. So that's like the carbamazepine or oxcarbazepine. That's their mechanism of action. Then we have a medication like ethosuxamide that we talked about it. That is a T-type calcium channel blocker. While we have on the other side, for instance, with the GABA receptors, which are inhibitory, we have the benzos and barbiturate, and through different mechanism of action, some binding to inhibitory enzymes, some to the receptors themselves, causing inhibitory effect. And the one that I would like to just kind of show us is the levetiracetam Keppra that has quite different mechanism of action. So it is actually interacting with a specific protein, which is called the SV2A protein, that inhibits the release of glutamate from the vesicles that they are stored in to the synapses. So that's kind of a unique mechanism that is different than the others that we talked about. After we understood a little bit the mechanism of action of the medication, the first thing that we like to know when a patient had a seizure is whether it was a partial onset seizure or whether it was a generalized onset seizure. Because we have some medications that are relatively narrow action, where they are only efficacious for partial onset seizures. And some examples would be the phenytoin, the carbamazepine, the oxcarbazepine, and gabapentin, for instance. And some of this medication, especially the carbamazepine and the oxcarbazepine, can actually worsen some of the generalized seizures. For instance, they might worsen absence seizures, they might worsen myoclonic seizures. Then we have the medication that have a very narrow potential of seizure control, which is the ethosuxamide. It's only good for generalized seizures and only for absences. It usually is not going to work for tonic-clonic seizures. And therefore, if we have a child who has one of the absence epileptic syndrome, for instance, childhood absence epilepsy, that usually do only have abscenses or mostly abscenses, we are going to start them on ethosuxamide. On the other hand, if a child would have juvenile absence epilepsy, where the frequency of tonic-clonic seizure or sometimes myoclonic seizures is much higher, then ethosuxamide might not be a good choice for them, and we would need to have a medication that is more broad spectrum. Then we have the medication that are very specific for a specific epilepsy syndrome, like the ACTH and the vigabatrin that we would choose for infantile spasm. And we have some medication, or a large portion of our newer medication, that are actually broad spectrum and are good both for partial seizures and for generalized seizures. And examples are the Depakote or valproic acid, lamotrigine, topiramate, felbamate, zonisamide, levetiracetam, clobazam, lacosamide, and parampanel, one of the newer that came out. I put the zonisamide here under myoclonic because it is known to be quite a good medication for myoclonic epilepsy. This medication originally came from Japan and was tried on, they have a large population of progressive myoclonic epilepsies, and it was actually very successful. And this would be one of the medication that we would try after we failed some other medication like levetiracetam that we would use for myoclonic seizures. So how good are our anti-epileptic drugs? So this is pie is a very famous one, and we see it almost in any talk about epilepsy and treatment of epilepsy. It was a study that was done by Kwan and Brody to show us what can we achieve with medication. And this is started with about 470 patients who were not treated yet with epilepsy. And when they received the first anti-epileptic drug, about 47% became seizure-free. The ones who were not seizure-free were tried on a second drug. And this is again, this was monotherapy, and the second drug was again monotherapy. So we started the second drug, we stopped the first drug, only 13% more became seizure-free. On the other hand, after they failed the first and the second drug, and we tried the third drug, this time it could have been either monotherapy or polytherapy, only 4% more became seizure-free. And by continuing with the fourth drug or fifth drug or the sixth drug, it actually did not increase the seizure freedom. And we have about 36% of patients who will not be seizure-free on any anti-epileptic drug regimen. And this is especially important for us epilepsy specialists and pediatric neurologists to understand that if a patient is not seizure-free after 2 or 3 drugs, this is now the time to think about other treatment options, like for instance, the ketogenic diet or the VNS or epilepsy surgery. And this is already something for a different talk. And interestingly, the same figures are also now present with the newer anti-epileptic drugs. Like I said, we do not have more success with the newer generation. We tried to summarize some top facts about each medication. Of course, we couldn't have just 10-hour lectures talking about each medication, so just few of the important things. So phenytoin, it's really in children mostly used for status epilepticus. We rarely would use it as a maintenance medication. It's probably still the most common medication used in adults. One of the major side effects that we don't like to use it in children, except for that I said before that the absorption is not as great in young children, is that it really causes quite severe gingival hyperplasia and coarsening of the facial features, with hirsutism and so on. And it's definitely not appealing to children. Second one is the carbamazepine, and I put it together with the ox carbamazepine because they have some similar features. Both of them are only good for focal onset seizures. They're not the same medication, even so we think that ox carbamazepine is maybe the second generation of carbamazepine, but it's not true. We have patients that will do well on carbamazepine and would not do well on carbamazepine, and the other way around. With carbamazepine, one of the problems is that it has an auto-induction quality, which means that you might increase the dose, but what you actually do, there is actually just increase in metabolism of the carbamazepine, and you increase only the toxicity by increasing the toxic metabolite, but you're actually not increasing the efficacy. This feature is not seen with oxcarbamazepine. And with both of them, you can see hyponatremia, and this is something that we have to monitor. Etosuxamide is, as I said, the first line for absence. It's a well-tolerated medication. Probably the most common side effect is GI irritation, and recommend to take this medication with food. Phenobarbital, one of our older medication, used mostly as a first line for neonatal seizures. We still have some older patients, 30 years old, 40 years old, most of them in nursing homes that are on phenobarbital, probably since they were neonates. We have still quite a lot of patients that come from immigrant countries on phenobarbital for their seizure control. However, we know that in toddlers and young children, it can have major side effects, especially of hyperactivity and behavioral difficulties. We know that use for the long term can decrease the IQ. And we have to know that if we want to stop them, we have to stop phenobarbital or wean it off, we have to do it very slowly due to possibility of withdrawal or rebound seizures. Valproic acid, probably still one of the most effective medication that we have, with very broad spectrum and good for multiple seizure types, including absences, myoclonic seizures, generalized tonic-clonic seizures, even atonic and tonic seizures, maybe a little bit less for focal seizures, but it's still effective. We don't use it because it has so many side effects, and we have others that have less. The major thing is liver toxicity, and especially in children below age of 2 years. So this would be a medication that we do not like to start early. It's an idiosyncratic reaction, so you sometimes can't predict if it's going to come. You can also have just elevated liver function test, and usually, I don't know what Laura you would do, I allow up to about 3 folds increase in liver function test before I decide that I have to stop Depakote.
No, I agree. I usually will, it's not uncommon, especially young children, they get viruses, their liver functions go up maybe 2, maybe 3-fold, and I'll watch them and I'll repeat it, and I might reduce their dose if I have to before I'll abandon it totally.
Probably the major side effect that we have to stop the medication for is weight gain. Then there is also some hair loss, and not just hair loss, but also change in the hair texture, some tremors. It has quite a major cognitive side effect on learning and attention. Another thing is inhibiting of platelet function, both in decrease of the number, so we can get thrombocytopenia. And the second is increased bleeding time, where we see that the kids get easily bruised. And then I didn't write it here down because we're going to talk a little bit about it later, is its teratogenic effect. So this would be a medication that has a lot of side effects, has many of them during pregnancy, and we try to avoid it in women of childbearing age. Lamotrigine is another broad spectrum medication. We like it quite a lot. The major side effect that you have to remember is the Stevens-Johnson syndrome, and there is some typo here which can be avoided with slow titration, like Lori said in the beginning, for whoever was present. It's some medication which cannot start very fast. And to avoid Stevens-Johnson syndrome, it will take us probably 2 to 3 months to get to a good lamotrigine dose. I would say that if we would do it very, very fast, there's going to be quite a higher rate of this life-threatening rash. The other issue with lamotrigine to remember is that lamotrigine is affected by oral contraceptives, so not the other way around. So if a female patient is on lamotrigine and then starts oral contraceptive, her levels may decrease by 50%. This is also true during pregnancy. So it has to be monitored. Levetiracetam or Keppra is probably the first one choice for almost any seizure type except maybe absences. Even focal seizures, some would start nowadays levetiracetam rather than one of the more narrow spectrum medication like oxcarbazepine or carbamazepine. Especially if we have seizures that we are not sure if they're generalized or focal, that would be the first choice. It doesn't have any interaction with any of the other medication compared to some of the older generation that are either inducers or inhibitors. The major adverse effect is not systemic, so we don't have to worry about hepatic function or kidney function or bone marrow suppression. It's mostly mood and behavior, so it can cause irritability, worsen mood and behavior. Anecdotically, we add pyridoxine or B6 sometimes to the Keppra and to improve the irritability and the mood changes. And it has quite a good cognitive profile. It does not, it's one of the medications that affect least our learning. Same actually with lamotrigine is also a very good medication for learning. So if we have to think about that, a child with already learning disability and difficulties, lamotrigine and levetiracetam would be a very good choice. I put Topamax and zonisamide again together because they have very similar side effect profile. One of the major one is anorexia and weight loss. So it doesn't work well with children who are very picky eaters and anyway underweight. It has quite a strong cognitive effect, especially on language. It can cause anhidrosis and risk for kidney stone if not well hydrated. And the last one I think that we are going, oh no, there's another one, but felbamate is maybe a medication that you don't hear so much because it's never used as a first line. It's always used for refractory epilepsy. It is quite efficacious for syndromes like Lennox-Gastaut syndrome, where we have multiple seizure types, or Dose syndrome, where some would maybe even start it as a second-line medication. However, due to both risk of aplastic anemia and liver failure, it is used in really cautiously. The aplastic anemia was never reported in young children. It is more reported in younger women, and many times they also had some other autoimmune disorders. So I have to say that I have not seen it in any of the children I treated. However, usually we have the family sign a consent to start treatment, and we have to follow initially their white count and CBC every 2 weeks. And last but not least for today are the benzodiazepines, who come in many different formulations. They are the first line for status epilepticus or prolonged seizures, and we have the diazepam, lorazepam, and midazolam with the IV, rectal, and nasal formulations. Then we have some of the PO formulation like clonazepam and clorazepam that we use. They're quite good for children, for instance, who have cerebral palsy, because they would have also a muscle relaxant effect, especially with a lot of, if a child suffers from spasticity. Their adverse effects are mostly CNS depression, respiratory depression, they cause dependency and tolerance. And again, if we need to wean them, or if the patient is not compliant, they can cause withdrawal seizures. They're also used for other indication like insomnia, anxiety, and some movement disorders. And clobazam, who is under the benzodiazepines. However, we use it, I would say now much more frequently as one of our more common anti-epileptic drug. Has a broad spectrum FDA approval for refractory seizures, especially in Lennox-Gastaut syndrome, and it's very efficacious for atonic and tonic seizures, and is used quite frequently.
Renata, I would just add about clobazam before we go on to the next slide is that the reason that we prefer this over other benzodiazepines, one is that it's very efficacious, and part of the reason it's efficacious is we can use dosages without getting the same sedation as we do with some of the more traditional benzodiazepines. And the second thing that's unique about clobazam from the others is there's less tolerance. So that if you start somebody on diazepam or lorazepam, you can be sure you're going to have to increase the dosage relatively frequently for the same amount of efficacy. Whereas clobazam doses tend to stay pretty static over time and just adjust for growth as opposed to tolerance.
I'm going to talk a little bit about dose-related side effects. So central nervous system depression. Almost all of our anti-epileptic drugs in high doses, and sometimes even in therapeutic doses, will cause lethargy and sedation. Usually after a few weeks, with some of them, the child gets used to it and will have maybe again lethargy and sedation with the next increase in doses. However, with some of them, it's more frequent to even have incoordination, ataxia, visual disturbances like diplopia, and visual blurring. This is one of the side effects that may make us decrease the dose or sometimes even stop the medication if the child cannot tolerate. Then we have the medication that have more cognitive and behavioral side effects like the phenobarbital and Depakote and Topamax and zonisamide and gabapentin, and to some degree even carbamazepine, our old good Tegretol. The medication with the least CNS side effect, as I said before, the lamotrigine and levetiracetam. And to minimize side effect, we can choose to do a slower rate of titration. So rather than starting high and having the patient fail the medication due to side effect, if we're not in a rush, if patient doesn't have very frequent seizures, we can do it slow. Introduce first at night. So most of the time we'll start the first dose at night for a week or few days, and then just start the daily dose. Use the lowest effective dose, so not go immediately to the highest recommended dose, because some patients might do better with lower doses. And then there is this, over the last few years, the thinking of rather than having patient only on monotherapy, let's say the patient is on Keppra, and we increase the dose and the patient becomes a little bit moody and maybe more depressed or more anxious. Rather than pushing the Keppra higher, it still has seizures. Rather than pushing the Keppra higher or giving up, we can introduce a medication that might counter-effect the side effect, like, for instance, lamotrigine, that we know is a good mood stabilizer. And we can have the patient on 2 medications at lower doses that affect different mechanisms and might give us actually better results than one medication at higher doses. Few medications that have a high teratogenic effect, and so this is implication for women and girls. One of them, which is probably the most known is Depakote or valproic acid that has quite high rate of neural tube defect and other major congenital malformation. Lori, am I right that in the last AES they talked something up to 20%?
Yes.
So Depakote, even not very high doses, initially they said not more than 1,000 or 1 gram in pregnancy. Now they say less than 600 milligram, which is really a tiny dose during pregnancy. Very high rate of teratogenic side effect, and it is not recommended to treat females of childbearing age with Depakote, and we have very hard time, especially with our adolescent girls that tried already few other medications. For instance, for condition like a juvenile myoclonic epilepsy, that we know that Depakote is very efficacious for the syndrome, and they continue to have seizures. We hesitate to start them on Depakote. If it would have been a male patient exactly with the same epileptic syndrome, he would have gotten the Depakote. So there is now a lot of controversy in the community what to do with it. In Europe, they actually have the patient sign for consent. In some places, they want the patient to be on contraceptive before they would start on Depakote to try to avoid pregnancy. Other medication that can have teratogenic, and what I didn't say, so it's not only that we have malformation, but we know that babies of women exposed to Depakote have higher rates of cognitive deficiency, so decreased IQ, and other disabilities, including autism. So higher rate of babies that were exposed to Depakote. Other medications are the carbamazepine and lamotrigine that can have mostly craniofacial anomalies like cleft lip and palate, and also neural tube defect. And phenytoin that can have a whole syndrome of fetal Idon-Twin syndrome that has both craniofacial abnormalities as well as hypoplasia of digits. So what do we try to do? We know that especially the neural tube defect and some other craniofacial anomalies might be related to folate deficiency. We know that women with epilepsy, not treated with any medication, have higher rates and higher risk of neural tube defect compared to women who don't have epilepsy. So epilepsy by itself increases the risk. And then if you are on this, any of the medication with higher risk, it of course increases by much more. So we place every girl in the moment that she started with her menstruation on folate, and we usually give at least 1 milligram of folic acid. So there is now again some controversies, because there is one paper that came out that said that high folic acid during pregnancy increases autism rates. Did you hear about that, Lori?
I did. So I think we'll bring that up in another webinar when we talk about reproductive issues in females.
So but we here nowadays in our practice make sure that each girl should be on 1 milligram of folic acid. The other important thing, especially again more in females, but also in males, is osteoporosis. And this is mostly seen with medication that are inducers like phenobarbital, phenytoin, and to less degree carbamazepine, and also Depakote that is actually an inhibitor. What we do, we check vitamin D level, and we supplement our patients with calcium and multivitamin, and at times also consider bone density scans. Just a list of which medication are inducers of the cytochrome P450 in the liver, and therefore will have more interaction with other medications. Major inducers are the carbamazepine, phenobarbital, primidone, to a lesser extent, felbamate, topiramate, and oxcarbazepine, and the inhibitor is Depakote.
And I guess the medicines, if for pediatricians that you have to think about most interacting would be antibiotics, because we use antibiotics pretty frequently for an ear infection or strep throat. And so you can anticipate that the levels will be off when you start an antibiotic. The second group of medicines I think we pay a lot of attention to are the oral contraceptives. So if a child is on, a young gal is on carbamazepine or even oxcarbazepine, and then you start them on an oral contraceptive, they're likely to have breakthrough bleeding and a much higher rate of conception. Oh, you had that below. My fault, Renat.
Okay, doesn't matter. And I think the one that I see most is erythromycin and tetracycline. So actually what you get if you have a patient, so that's a little bit of a reverse effect. It decreases the metabolism of carbamazepine, and we actually get carbamazepine toxicity. So that would be the patient who starts to become dizzy and has nystagmus and ataxia when they're sick and receive erythromycin. And like Lori said, with the contraception, all the inducers are going to decrease the efficacy of our contraception, except for lamotrigine that has the reverse effects of contraception, like we said before, will affect lamotrigine levels. The medication that would need lab monitoring are the ones that are here on the list: carbamazepine, valproic acid, felbamate, and oxcarbazepine. So again, children who need a lot of, who are afraid of blood draws should not be on one of this medication if possible. And levels are not really needed on a routine basis, especially with the newer medication. We use them mostly to follow compliance or to find a baseline, what is a good baseline for the patient to be on, but not really to help us with toxicity. The other, I think this is the last topic before we go to a few vignettes that Lori is going to discuss, are some medication that we can use for comorbid conditions. So our patient with the seizures might have also migraine, might have mood disorders, might be obese. So we can use medication that have also indication for this disorder. So for instance, valproic acid and topiramate and gabapentin are prophylactic medication for migraines. Topiramate and zonisamide and felbamate cause anorexia and weight loss. So if our patient is very obese, that might be some of medication that can be used. If patients have mood disorders or aggression, so some of our medications are mood stabilizers like valproic acid, lamotrigine, oxcarbazepine, topiramate, and carbamazepine can be used. And then if we have patients who have to undergo transplant or HIV positive, get chemotherapy or some other, or it's on multiple medications, we would like to use medications that are not enzyme inducer, and we would probably would like to use mostly medication like Keppra or levetiracetam that does not have a lot of interaction with any other drugs. So we will start with a few cases. Lori, do you want to read them?
Sure, we can go through them and then we'll have a discussion back and forth, because there isn't one approach, I think, to the little vignettes that we're going to discuss. There's really several different approaches that could be done. So an 8-year-old boy with self-limited epilepsy of childhood, that's the long name for what we always said was Rolandic epilepsy. So a benign or easy to control epilepsy most of the time. He's had 1 to 2 nocturnal seizures monthly. And sorry, I have to reduce everyone's videos to see the slides. The morning after his seizure, he is groggy and less focused. He has missed school and parents have missed work. And so the question is, would you treat or not treat? As Renat had talked about at the beginning of this presentation, for epilepsies like Rolandic epilepsy, we do not have to treat necessarily because it does not impact the prognosis. However, we may opt to treat because it has an impact on quality of life. And so the question would be, is this enough to say, let's put the child on medication because it's impacting quality of life? He's missing school, parents are missing work. He probably misses a day after every time he has a seizure. My sense would be I would probably treat this child. I have kids in my practice where I have actually put them on medicine, even though I know it's not going to impact their long-term outcome. And then the question would be, what would you use? Renat, would you treat someone like this?
I think I would go with parents' preference.
Right. Some parents are more tolerant. Sometimes they'll wait several months before they actually decide to. I agree. And then assuming that the parents would like to treat because it's impacting their lives, what would you use and how would you give it? I think Renat and I would opt for one of the less none of the medications, the least amount of side effects, the easiest to administer, and one that we can probably give primarily at night. So levetiracetam gets into the system very quickly, so we might give a higher dose at night and a lower dose during the day, or that oxcarbazepine could be used this way as well. But we're going to pick one that doesn't require blood work, is less likely to affect organs, less likely to impact learning. Any thoughts that you have, Renat, on this case?
I think that probably in the past I would have used oxcarbazepine. Nowadays, probably I would use levetiracetam because it's a little bit better side effect profile, especially if the child doesn't have any behavioral issues at baseline.
Right. There's actually a study that also shows gabapentin for this particular type of epilepsy. We don't think of gabapentin as a very robust medication, but there has been a trial that was done by Blaise Bourgeois that actually showed an impact, and it is a very benign medication.
Well, I think in the past, I would say when I was a resident, it was probably our drug of choice for this condition.
Was gabapentin? I think we're good for the next vignette. So the next one is really just focusing on how do we use our medications to treat comorbidities. So a 15-year-old boy with temporal lobe epilepsy and focal seizures with altered awareness, which is the fancy term for saying a 15-year-old boy with temporal lobe epilepsy and complex partial seizures. We just have new terms now. So basically periods of confusion and altered awareness. In addition to having these, he has migraine headaches and a language-based learning disability. And what are some possible ways to treat this boy without causing more problems? So one of the things we want to think about is what's the medication that we can use for focal seizures? And truly most of them, with the exception of ethosuximide, we could consider, though some people feel from the old trials, the VA studies, that maybe valproic acid is a little less effective than the others, but it's still on the table as an option. But we don't want to make his language-based learning disability worse. So I might steer away from things like topiramate, valproic acid, things with a lot of sedation, like phenobarbital. And there were several on the list that Renat had discussed earlier. We don't have to go through each one, but I want to try to avoid that. And then I'd say, well, what medications might be helpful for migraine? Well, some of the ones on the list are topiramate, which may exacerbate his language-based learning disability. Valproic acid may be a little less effective for seizures, and maybe have some impact on learning, but it's a little bit less. Gabapentin, it can work for partial seizures, but it's not highly effective. And so I think my approach in this young man might actually be low dose of 2 medicines, polytherapy, as opposed to just a single drug. I think it's going to be hard to get a single drug that doesn't exacerbate other problems while trying to treat the ones that are problematic. So for example, I might pick levetiracetam with low dose gabapentin, or levetiracetam with low dose topiramate, as opposed to high dose of any one medicine. Any thoughts that you have there, Renat?
No, I agree that I would choose 2, but they don't have both of them to be anti-epileptic drugs. So I might use one for the seizures.
Right.
Might use amitriptyline, or beta blocker, or calcium channel blocker for the migraines. Again,
right.
If it's a child who can't fall asleep, maybe amitriptyline would be a good choice. If he's a very anxious child, maybe a beta blocker would be a good choice. But I agree that I probably would be hard to cover with one anti-epileptic drug both his seizures and migraine.
Okay, and then the last case. So how do we might approach a young female of reproductive age? So a 16-year-old female with new onset juvenile myoclonic epilepsy. Remember, this is a primary generalized epilepsy, one that continues into young adulthood. People usually say well into the 4th decade. She's sexually active and is on an oral contraceptive. Now you need to put her on an anti-epileptic or an anti-seizure medicine. How would you treat her seizures? And keeping in mind that we need to think about contraception. Will she stay on the oral contraceptive, or could we pick something else? So for example, young female long-term lamotrigine might be a really nice medication long-term for her, although we'd have to be careful about bringing up myoclonus. It can be very effective for juvenile myoclonic epilepsy. It's very nice because it has less side effects in terms of long-term impact on the developing fetus should she become pregnant in the future, but interacts with her oral contraceptive, and you're going to have to use a dosage twice as high as you would if she was not on an oral contraceptive. So maybe you could do that. You could do lamotrigine plus an IUD. You could tie levetiracetam, which does not interact with her oral contraceptive, and we think pretty safe in terms of the spectrum of what might happen with the anticonvulsant in terms of her later risk to her unborn child. So levetiracetam, although we don't think it's quite as effective probably for juvenile myoclonic epilepsy. And then the other thing that people sometimes do is do a combination. So give the levetiracetam to really control some of the bigger generalized tonic-clonic seizures, a low dose of lamotrigine to even out the mood just because she's a female and she's a teenager and maybe she's going to have more mood side effects. And then maybe consider an IUD, or we'd have to think about the impact of the oral contraceptive on lamotrigine. But there's not one answer. It's just that you have to think about balancing side effects, drug interactions, as well as the longevity of the underlying epilepsy syndrome. Any thoughts there, Renat, that you would say differently?
I think it's the same. And for your last question there, what medication poses the greatest risk to future pregnancies? I think if we talked about it, it's the valproic acid that we're going to try to avoid if possible.
Right. It is very effective for this syndrome, and sometimes we have to go there, but we try to avoid it. So I think, Renat, is that the end of our talk on introduction to anti-seizure medicines?